Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between. When you start with PCC, you get more than an EHR. As an active participant in the pediatric community, we're proud to offer a lively peer community of PCC EHR users, a free annual users conference, and new resources that empower you to prioritize your patients. Learn more at pcc.com. Again, pcc.com. Hello, George. It's Tuesday morning, and we have another phenomenal guest today.
Today we have Dr. Stephen Hirsch. He's competing with the background of the musical instruments for our podcast. And the topic of discussion is going to be independent practice in the suburbs of DC, a day in the life. Let's take it away.
Dr. Hirsch and I share many things. We grew up in the same neighborhood outside of DC. We obsess about details that wow the customer and lead to processes that have excellent outcomes. His office in Rockville, Maryland, exemplifies his passion for the profession and his love for the art of caring for children as an independent pediatric practice. Stephen, it's a joy to have you on the podcast.
Thank you.
See you.
Pleasure to be here.
Thank you for having me in your office.
Oh, of course.
Stephen, we always start with the same question. Why did you become a pediatrician?
So one of those people that knew it from a young age. So around the age of 7, give or take a year, I just declared to the adults in the world that I just wanted to be a pediatrician someday and have my own office. I think around that age is when you're old enough to find that the infants and toddlers are different creatures and beings. And I find that little children, I love the way they're wired. They're hysterical, their antics, their thoughts, their enjoyment of the world. And there's nothing like it. So if you can have a career or that's what you do most of the day, it's wonderful. I like science. I like biology. The human body is fascinating. So it just made sense for that to be my career. And going through medical school and residency, general pediatrics always called out to me.
You're very intentional, and you pay a lot of attention to every detail in this office. What is the importance of attention to detail, intentionality, and the aesthetics of the office on your workday and your patient?
Yeah, way back in 2007, when I decided to go out on my own and build an office, I had a vision, and I knew that I was going to be doing this for the next 30 or 40 years. And I had that idea and thought. And so I thought, well, if I'm going to do this for several decades, let me try to get it right. Let me have this vision. Let me work through it. Very supportive wife. We just had one little child back then, so it was easy to branch out. And I knew that when you're building an office and you're making a design and experience for the family, like they will extrapolate from that. Wow, you put this much intention into your design and every little detail or experience is great. You might actually provide that same level of care to my child. It's not always true. Offices that are not designed as well can provide fantastic care, and the best looking office may not be good care, but families often do extrapolate that. And I think that's just been something that I've always thought about. What can add to the experience of my patients, my families? And we designed the office and we made it very intentional. So we wanted the parents to show up and feel relaxed and comfortable. And we wanted the kids to be able to play here and enjoy their surroundings and just feel like they were not in a doctor's office. And so we tried to make it as unique as possible and surpass expectations. And it took a lot of work. It took over a year to build it out the way we wanted it to. But when we opened it, we weren't that busy at first. It's just a brand new office, but it worked the way we wanted to. And we haven't really changed it. We've expanded several years ago, but no, we kept it the way it is.
Do you think that has helped you recruit support staff and maintain them here longer?
Yeah, I do think the environment you create, the physical space, as well as the atmosphere of your employees, it does create a feeling that sometimes makes families want to be here and join here, and your team members, your support staff, and your doctors also want to be here. So I think it's been helpful, and just to how we invest in the practice, the aesthetic.
Unlike most pediatric offices, your office is clean. The countertops are not cluttered. Everything is clean.
Right.
You walk into any other pediatric office.
Sometimes a little OCD is helpful. And I do walk into the office most days, and I'm just going to walk up and make sure I don't trip anything, but I'll kind of do this and just look at the floors and the ceiling just to make sure everything is where it should be. And when we get it right, we leave it. But yeah, no, I'm not a clean freak or a germaphobe, but I do think it's important for things to be a certain way. And to maintain it. And if something is getting worn out, we're going to replace it. We're going to repaint. We're just going to keep it looking the same way. The analogy I always think about is going to a nice hotel or a nice restaurant. When you go to a nice hotel, a nice restaurant, you're not going to leave there thinking it was really nice, but that bathroom was just not good. Or I showed up and that hostess stand was just cluttered. Or you're going to feel like you're taken care of every step of the way.
Yeah.
So I want our families to feel that way.
Bathrooms are generally important in a medical facility, especially in peds. I have my staff looking at the bathrooms all the time because if you take care of the bathroom, it becomes a pigsty. And kids, people have to take care of it. That just shows that you care about everything else. You care about the bathroom.
Bathrooms are hard to keep clean when you have lots of kids coming in throughout the day.
Well,
The other thing that just drives me absolutely bonkers is when I go to the doctor's office, pediatrician or not, I'm visiting someone, and they have the old school front desk with the glass window and they shut it.
Yeah.
Oh my God. I think that is the rudest. That the message is, we don't want you here.
Right.
Get out.
Yeah. If you go back to the analogy of walking into that hotel where you're a guest, you're visiting foreign place, you want the experience to be nice, but you want to emphasize. Yes. I think a lot of ways that doctors' offices, for better or for worse, they tend to survive. Not the same level of competition that drives businesses to improve their function. Certainly if you walked into a nice hotel and there was that glass front and they were very impersonal to you, you probably wouldn't stay there again, or you would not write a good review. But doctors' offices will practice the way they've been practicing for decades, get by, but they could be doing better.
When you go to a lot of systems and hospitals, it feels very cold. They probably have some very expensive artwork in the lobby. That's about it.
Yeah.
Yeah. You could never do this in a big system.
No.
They wouldn't allow you to.
No.
And Stephen, why do you think that independent practice is the best for pediatricians and the patients that we serve?
Yeah, I think that's a great question. Certainly, I don't begrudge any pediatricians who decide it's just not for them, or they've been running a practice for decades and it's just getting the practice management is complex and they decide to join an entity, private equity or hospital. But for those people that stick it out and have a strong interest in the practice management and the running the practice, I think a well-run independent pediatric practice can outperform as far as patient satisfaction, quality measures, employee satisfaction, any owned practice. Because at the end of the day, when we make decisions, we're always going to ask ourselves, what's in the best care for the children? So what's in the best care for the children? And to that extent, what's best for the doctors and what's best for the support team? Because if it's good for us, it's going to make us feel better and want to practice better. And I think when you have the ownership by another group, they might focus on other things. They're looking at maybe short-term gains, or the hospital's more concerned about just having patients in their network for referrals, but not like the actual experience of the patients. And I also think independent practices where they can do better is if they can manage the whole levels of practice management. It's all part of the relationship. And I've heard from many families, they'll say things like, I love that doctor, but I don't like going to that office, or I don't like the billing. And you'll see some negative reviews. Some one-star reviews for practices have nothing to do with the doctor. They'll be like, Dr. Jones was great, but I got this bill and it didn't make sense to me. And I called and they made me pay, and they get very frustrated and stuff. And that's often what happens when you are not independent practice. We do the billing in-house, we do practice management. We make sure that relationship is managed, and just to make sure that patients, we're understanding each other.
So Chip Hart says that you cannot scale Stephen Hirsch. And that's why the PE model doesn't work in healthcare, because there's only one of you. And that relationship you have with each one of your families can't be turned into a McDonald's or into a Burger King. Mm-hmm. And I think that's what you're saying too, that you're very intentional. You have a vision. You have a way that you want to take care of your patients. It might not fit me because I'm not care about this nice room and you would spend time. I just want this kid to have an ear infection or not.
Yeah.
But you can't scale it. And
yeah, you can scale a little bit. It depends where your interests are. When I opened in 2007, I love the idea of just being in my office and just controlling the care and the relationships. And very early on, we got busy, we got referrals, and I quickly narrowed our patient referrals just to under 4, under 2, and now newborns. For many years, we just take newborns because we're just trying to do a very slow growth to be very intentional. And because I that's what I enjoyed the most, the relationships. And I found that when we were getting families with teenagers that we never knew, and we were very proactive with their care. We couldn't handle that. And I knew it would quickly outgrow just being me. I liked being by myself. I was solo up until about 3 years ago, and I brought on then 2 more doctors. But no, I think you can. So if you want to scale it up, you can, but you're going to lose a little bit of that relationship because you're not everywhere at all times. We have added 2 providers in those 3 years, and I don't think it compromised at all the quality of care. They're great doctors. They're young, do a lot of mentoring and training. When they started working, I think most doctors with their first job, here's an hour of orientation and then go. You go see the patients. But we did 3 to 4 weeks of just mentoring where they would follow me to patients. We would talk about the patients. We'd look at the documentation. How do we do it? And then I would follow them closely for about 6 to 9 months, look at their charting, look at their visit. And we sit in the same room. We're with feet within each other. So we're just trying to make sure that we're practicing the same way. We keep the messaging the same. I've just never had an interest in franchising there.
I think
Some experiences that I had with training of newer physicians, we used to think that the computer was the problem. So we used to train them for 2 weeks on the computer. I'm starting to see that the computer is really not the problem anymore. So what we're doing is we're teaching them the computer pretty quickly, like in a day or two. And then we're letting them run the show in the room, and we're just not saying anything and letting them talk. So they're learning our ways. I'm also finding a little bit like if I find interesting cases in the room, I try to bring them in to see it. Some of them say to me, do you think I don't know that? Do you think I've never seen that? They look at it as you're watching them. Dr. Riley, my associate, my partner at the office, he looks at the charts. They feel like they're being bullied. Somebody's watching them. Why are they looking at their charts? So there's a little bit of it's a dance that you got to do without upsetting somebody.
So first of all, George's experience at RBK was pretty interesting when he got there about 80 years ago. The senior partner,
50 years.
not more, but about that. The senior partner just took a chart, handed to him.
Yeah.
Go see the patient.
Yeah.
You remember that?
Welcome to RBK Pediatric. It's called Reichman, Brown, and Kaplan Pediatric because you had to have a marquee. Welcome. Room number 12. You have your first patient. Good luck.
Yeah. I also think a lot of the owners are a bit burnt out when they bring on people. So they're just so happy to have some relief. And
I don't think Dr. Reichman knew what the word burnt out means.
But I don't know. Maybe it's my age, but since I'm always moving from practice to practice, is what I do nowadays. But when the owner comes back, I sit down with them with all the difficult cases that they need to follow up, because I may handle them one way, as you might handle another way.
Yeah.
But they need follow up. Mm-hmm. And the electronic medical record is not great at conveying exactly what I'm thinking. Mm-hmm. And so if it's a complex patient or maybe a problem patient, I want to make sure the practice owner is aware of it.
Mm-hmm. Yeah.
I would hope that you would write that in your progress notes. But I'm looking at it from the point of view where we get a lot of patients a year. Do you really think I'm going to run around with a little piece of paper of the notes that I took from your discussion with me to follow up this patient? You should book an appointment. You should write a good progress note, and your progress note should convey your message to me.
Well, you have a very large practice. It's a little different.
Yeah, I know.
Than 1 to 3 person practice. And even though you try to convey the message on the note, sometimes it's just not understandable. Like I called Child Protective Services on a 17-and-a-half-year-old.
Okay.
And I documented that I called, left a note, the report number. And when I told Dr. Sinha why I did that, it was like, here's why I did that. This is a 17-and-a-half-year-old that's lost 25 pounds in the last 2 years, is down to 90 pounds. The first time I saw her in your clinic, her heart rate was mid-50s. Sodium, potassium, everything else is normal. I put her on Lexapro, and I asked her mom to go see the eating disorders clinic at Children's National. She came back, saw you. She hadn't made the appointment. You had them follow up with the day that I was covering your practice. I again talked to the mother. She stopped the Lexapro, and the kid gained a pound, and she said, she's all better. And I said, I want to see you back in a month for a weight check. And by then I need to see an appointment with with Children's. And she said, is it really necessary? I said, I'm telling you, I want to see the appointment. And she canceled the appointment and it was a no-show. That was the last straw.
Mhm.
But I can't really convey all of that on a progress note in the middle of ECW. It's impossible.
Right.
But she looked at me, she says, oh yeah, I know who this is. The mom's really tall. I'm worried about that kid. What are we going to do? I said, we know you're going to get the call and she's going to be angry because that's what's going to happen. The manager knows when she calls back and she screams and says, I'm a horrible person with 3 horns.
Yeah.
You're going to go, oh yeah, I know you are.
Yeah.
But now with your medical scribe, your AI scribe, Herb, that discussion should not be anymore. You should be able to write your progress note.
If you know what's happening, some of these kids,
I'll tell you, if you're getting those visits a lot, you're gonna burn out there. But
Yeah,
hopefully
keep going.
that's a rare visit, and
Yeah, it's
most
an
of your
anomaly.
visits are just the
It's a variable.
the
You
run of
gotta
the
work
mill.
on
but then
Yeah.
the other 20 kids you see, there's no need for a discussion.
Right.
Right. Well, I always thought how funny it would be if I could just walk in there and just say exactly what I know and see and what to do with no discussion and just, okay, doctor, we'll do that. It's see, 100 kids per day. It would be really, but I've learned that charting is, I can chart fast, I can type fast, but the discussion is part of it. The complete visit and discussion and the outcomes, you just have to embrace that. That's part of it. And just, if some families that's where the relationships come in. You have relationship with families and you've known them over years, seen them many visits. You can move in and out of that room much faster because you have a level of trust, and that trust just goes both ways.
Yeah.
Which is why, as mentioned, when we would have families transfer their older kids that have multiple issues, we didn't have the trust there. And I don't blame those parents for questioning something that was out of their comfort zone. It would feel accusatory sometimes to them, and it'd be frustrating in that relationships. And I think that's where practices would really do better, is just when looking at like markers, is maintaining their family and minimizing transfers and saying what it is that makes people leave their practice sometimes for a different experience.
Yes.
Medicare thought that this relationship and this trust and all that was important for primary care physicians. And they created a new code, that G2211. Interesting enough, I think Medicare pays for it, but a lot of the commercial companies do not. And some of the commercial companies did, and they actually did the right thing and started paying, but they will stop paying in September. Some of the Medicaid lines of businesses, they do cover it. Yeah. But it's a good code. It's just like giving PCPs a raise to do the right thing, the relationships. Somebody thought it was a great idea, yet other people feel that they shouldn't pay for it. So it gets confusing. It's frustrating too. Why build a relationship?
That was the American Academy of Family Practice. It does a phenomenal work for the family practitioner doctors of America. Mm-hmm. They're really focused on what I call put the oxygen mask over your face first, which is the first thing I tell parents when they come in with a newborn. Parenting is scary. Have you ever been on a plane? They say, put the oxygen mask on you before you put it on the kid. Because if I lose the mother, I can't fix the kid. And we lose the pediatrician, we can't help the kid. And the American Academy of Family Practice is focused on their workforce 100%, so that they can provide the best care to the patients. And that's to be applauded.
In 2007, I opened the practice, and back then, eClinical worked with really good EMR. And I opened in 2007 with that, and was fairly content with that for a while, but then didn't seem to maintain their quality and their reliability. And I was having too many issues with them. And during COVID, it just went down again, and they didn't have good answers, no customer service. I'm like, I'm done. I don't want to be unhappy with my EMR anymore, because I see these clients with PCC and they're just strangely happy. I don't get it. It's just funny. So I called Chip. I said, Chip, we're leaving eClinical work. It's going to be you or another pediatric specific EMR. So sell me on PCC. Tell me what you think. And then I visited a couple practices with it. And I'm like, okay, this is good. We're going to do it. So we switched over in 2021, and I would have never looked back. But financially, of course, you get what you pay for, but I like customer service. And also going back to the patient experience, their patient portal, maybe it's better than it was 3 years ago, but no, hasn't. But the patient portal was really something that we wanted to focus on, because we liked the one login and password for the whole family. Parents found it very hard for ECW that each of their children had a different login and password. They couldn't get it right. We also get messages. Parents don't think it's a big deal sending a message about one child to another child's chart. For us, it's a really big deal because it's in the wrong chart. Like, you don't have that information anymore in the kid's chart. So you have to do copying and pasting. We didn't like that. And also, we didn't like, you couldn't send forms back and forth. And we fill out thousands of school forms every year. It's just so CAM form, school forms. and not having the ability to send them back and forth was just unnecessarily hard. And so with the portal, PCC lets us do that. And I like the dashboard, that I like the quality measures I'm looking at. And it's important to know where you are with other practices. But yeah, I think we're with PCC for the long haul.
PCC's like independent practice.
Yeah,
They
I like
pivot,
their
they
messaging.
adjust, they adapt, they listen. I've known Chip Hart when he was a little baby salesman. 96, he sold the product to my office. I came in as a young guy, and he said, "You're a young guy, your computers, go find us a practice management product." So I think it was Lycos back then, search engine. PCC popped up, and Chip Hart sent me this big box with a little laptop in it, and I called him up and demoed the product with him. It was a god-awful monochrome color, but that's how it was back then because it was efficient. It wasn't Windows-based, it was Linux-based or Unix-based, and the rest is history for PCC.
Yeah, I think the relationship is where it's like, if you have a problem or concern, you can call them, and maybe they can't fix it because it's an issue that they're working on, but they'll talk to you. You feel like you're talking to somebody and you know what's going on, and that means a lot.
They never blow off and say the other guy's problem.
Oh yeah, so or it's a known glitch will be fixed with a future upgrade, which it doesn't. And I swear, ECW, they would beta test their new version on everybody. It's like the new version hits your office and it just crashes. And
that's how these guys work. They build
something. It's time to move on. Yeah,
they build something and they put it out to everybody and they see what the problems are, and then
were you getting ECW through the children's CIN?
Eventually, yes. Initially, I had it myself. I had the server in my office. We were independent. The CIN came many years later, and then we did it through them.
Right. And Stephen, what quality measures do you focus on? You already told us one that I think is very important. Why do people leave the practice?
If people are leaving the practice, then you can learn the reason, and it's a reason that is something that you can manage, and it's something to think about. But I do think quality measures are important. I think benchmarking is important. You just know where you stand compared to other practices, because when we operate in silos and everybody thinks they're doing the best job in the world, which they may be for their office, but you may not realize that your neighbor one down the block from you actually has quality measures that are much better than yours. And I've always thought they can do it, then you can do it too. The things that I focus on the most, and we had a monthly dashboard from PCC. So there's, a few dozen quality measures, but the ones I look at the most are our checkup rate. Do every one of our kids have their checkups up to date? There's the 0 to 15 month range. There's the adolescents and teenagers. And we're at the high 90s for everybody for checkups, because it's just important. And if someone we schedule our checkups a year in advance, which is really important. I'd recommend everybody doing that. Change the culture so you can do that. But if we want our checkups to be up to date, and if someone doesn't have a checkup scheduled or they're overdue, we'll call them every week until they get on the schedule. And so the checkups are important. The vaccination rates are important. So, but when you have checkups that are up to date, your vaccine rates tend to be very good. But I also think our vaccination rates are very good. Our teenagers, I just was looking at before a meeting, our adolescent vaccination rate, we're at 90%, which is really good. Having an ACT or a Tdap in both HPVs for our teenagers, that's a level of relationship. People are skeptical sometimes of the HPV vaccine, but if they've known us for years and they trust us, and we say this is the right vaccine for your child, we get higher uptake from that. So
now let me ask you a question. In Maryland, is HPV required for school or not? Is it Virginia? It's a requirement.
No, I don't think so, because we have some families that don't get it, and they don't need exemptions.
Okay.
And the funny thing is that sometimes people look at requirements as what's necessary, but it's not really the best medicine or best care.
Right.
So
it just makes it easier because you got it.
It makes it easier.
It makes it easier.
Yes. There have been times when people will say, "Is that required?" And mostly for the 4-year vaccine. Yeah, I think the schools are going to want to see that, and I'm like, okay, we'll get it. I'm like, okay, then we'll do that then.
And then are you giving the HPV at 11 or 9?
I understand the reasoning for 9, but we're not having an issue with uptake. So we give at 11, we tend to have them come back in 6 months. And if they don't come back in 6 months, we complete the series at 12. 9-year-olds are still a bit young. They don't love the vaccines. And so if I can just limit the number of times they get vaccines, that works for us. And
because in New York, the QIP, the quality incentive programs, measure you at 9, not at 11.
Yeah.
So you're forced to give it at 9.
I just don't think we have a problem giving it at 11. I like not having to give vaccines an extra visit. And I don't think the outcomes are any less by waiting 2 years. So I'm happy just to keep them at 11.
And then it's scheduling a year in advance.
Oftentimes you'll know a year in advance when your vacations may be ish.
Okay.
You have kids that are, when they're out of school and when they're going to camp and stuff, you run around that. But if you have an idea you're going to take a week off in June or July, then just stick it on the calendar a year in advance so you have space there. And if you happen to get the wrong week, then as you're getting closer, you have a week that's open to move those appointments to the week you're actually off. The problem comes when people don't block time off and your schedule's already filled up. And 3 to 4 months ahead of time, you need to move an entire week's of appointments, but there's no space to move them. So our opinion is that if we're going to move your appointment after you scheduled it, we're going to accommodate you and make sure we get you in a time that works for you. Non-independent practices, all the time you'll hear, oh, the hospital called me, they canceled my appointment for tomorrow, they can't see me for 2 months. I'm like, that's absurd. That's rude, actually. So the key is just really getting that schedule, just asking your doc, what times you need to be off. The AP conference, all of us go to that every year. So we're going to block that out a year in advance. We're going to block the holidays out a year in advance, the vacation and block out in advance. And people don't mind changing appointments when you give them several month warning.
And so what do you do when you go to the AP and everybody's out? You just close and answer calls?
No, we don't close. So actually, when I opened back in 2007, I have a friend of mine, a colleague who has a practice down the street. She's a really good doctor. She's just really good with the patients. Her focus is more adolescent care, but she's great with all ages. So she covers the office.
Okay.
And she's been very helpful. We had one of our doctors was on maternity leave for 3 or 4 months recently. And so that was a little bit busier. So I worked extra. The doctor that was here worked extra. And then our covering doctor came in 1 day a week to help us with the volume. When I was by myself, the families would ask practice interviews, what happens when you're out of town? Is the office closed? And I say, the office never closes. Someone is always here to answer your questions. And if I'm not available, we'll have a covering doctor.
Oh, great. And then from the dashboard of BZ, what do you focus on financial benchmarking? Because you can have the best quality medicine. If you don't have revenue, you're done.
Oh, yes. You need the revenue to make everything run. So the things that I'm going to look at are a lot of the financial benchmark. First of all, I'm going to look even outside of PCC. Is the practice growing? Are we stable? So year to make sure that we're actually have good growth when the revenue is moving in the right direction. If your practice is contracting and your revenue is going down each year with your expenses going up, then you've got to figure out what's going on. But for the most part, the AR is very important. We do the billing in-house. I focus on the AR. I think most claims should be paid within 30 to 60 days. There's really no reason for them to go past that unless there's something unique, which means the insurance is giving us the runaround or the family's insurance wasn't active. I'm going to look every month and sometimes more often at where we are with our AR over 60 days and over 90 days. Another benchmark that may not seem financial, but it really does relate to it, which is actually, that's how I met Chip Hart, because when I opened the practice, I really focused on, I didn't like coming to the office when you didn't have to be here. I'm like, your child's pink. If you want them eye drops, be my guest. Here's the prescription. I sent it in. Use them or don't use them. Here's what I need you to do. So I really didn't want sick visits to come in, didn't have to come in. So that improved my sick visit checkup ratio, which is, I think, the number that is really the most important driver of the practice finances in many ways. I was at a conference many years ago, and Chip Hart was up there lecturing, and he talked about the sick visit to checkup ratio. If you convert every sick visit you turn into a checkup, like appointment per day, like how does that change your revenue? And I think those are accurate numbers. And that's how you can turn around sort of the finance of a practice. Now, that assumes that you're able to fill your slots when you remove the sick visits with checkups. If you're a practice that's struggling for volume and you just don't have enough volume and you're just not going to see patients, that's a different story. So your receptionist calls and says, "Hey, Mrs. Jones, your child is overdue for his 12-year checkup. We can see you in 3 months." That's just not going to work, right? You need to be able to have opportunities to see them. So I think focusing on that visit to checkup ratio is important.
That's where I disagree with Chip. All right.
Okay.
You should see well visit, yes.
Yeah.
But in order to do that, because you're going to go to the other extreme and you're not going to see patient, then you're going to have a triage nurse. The message is going to be, don't come to the office. Don't come to the office. You have to see people when they want them. Yeah, many times people come in. For them, it's an emergency. For me, it's whatever. It's pink eye. It's not that big of a deal. So you're trying to keep people out of the office.
We're not necessarily trying to keep them out of the office.
That's the feeling that they get.
Yeah.
We have a very good friend of mine that has excellent quality scores. He's the best quality practice in New York for one particular insurance company. Juan Espinoza, Brentwood Pediatric. He has a 5.0 and it kills me. We got 4.8. He converts a lot of if they come in for a runny nose, he looks to see, can this be converted to a well visit? And he often does that. Old school thinking was, they're here for a check, runny nose, let's deal with that and come back next week for a checkup or next month for a checkup. But people need access to care because especially this new generation of parents, everything is an emergency.
Yeah. Let me tell you how we manage that a little bit differently. So we don't actually have a triage nurse here. It's a different way of doing it. So we're very active in the patient portal. So when medical questions come in, they come directly to the provider, right? And our schedule, we probably see less appointments per day than most practices, or more checkups. And so we space out our checkups. We have time in between our visits. So we're always on the computer. I'm responding to portal messages, and the messages are very repetitive. And so we have good 20, 30 pages of kind of responses that we use a lot, and we just tailor them to what they're saying. And we offer them the advice directly from the doctor. So they feel like they might as well be in front of us. And we always will say, if you still have any concerns, please come in for an appointment. We have plenty of slots for sick visits. So we want them to know. And if they just write a message saying, hey, my child is this, I want to come in for an appointment, then they're scheduled. They don't have to go through anybody to get an appointment. They can always do it. But most are happy just to know that they've spoken to us. They have some reassurance. This is our advice. And that's where sort of making sure we all practice the same medicine, the practice that the advice is the same. And when they come in person, they hear the same words.
George is going to tell you this. You can hire another clinician and see all the sick visits and generate revenue.
The people on SOPM will say that's another service that you provided for free. All these things add up. That goes into physician burnout.
We'll tackle that in a minute, because I have a very interesting conversation on that. But first, before we go there, I want to just pick your brain a little bit. How does what you have built, which is a beautiful office, is very intentional, very vision driven, allowed you to recruit, hire, and maintain ancillary services like embedded mental health and lactation consultants, which most big practices can't even bring in, but you can.
Yeah. I think you have to be very intentional with that. If it's important for your practice, then you just have to start somewhere. And you go to I went to the AAP conferences, and I'd go to the lectures about embedding mental health and listen to their strategies and how they're doing it. And then you just decide it is good for your practice. And everybody will agree having that is good for the practice. Now, it's not going to be great financially, but what you're going to do is you're going to provide access to your patients for mental health care when you can quickly get them into that. So you're not in that room trying to manage the teenager's anxiety, spending a lot of time where you could be doing other things like keeping your checkups up to date. And I think if you're very intentional, you can do it. You just have to go out and find the person, and then you have to have the space. And I think that's where offices run into trouble. Is when I built this office, we had a bigger space. We're bigger than what we needed at first. So we grew into it, and we had the space, and we added space about 5 years ago. And you need to add the space, right? You need your therapist to have a dedicated room. We actually built a second room as a waiting room for the therapist because we didn't want the families waiting in the main area. It just is not comfortable for them. And so I think it can work if you're intentional and you just advertise and you interview people, and what you're providing them is a guaranteed source of patients. They don't have to deal with the scheduling or the headaches or the billing of it. And then I think if you pay them fairly, it works. But you just have to decide it's important for your practice.
Mental health today is very important. Yes, it's a time suck. But everybody talks about it. Insurance companies don't pay for it. That room costs rent. That person that's doing it is a social worker that probably wants to get a paycheck. She's not Mother Teresa. Yeah. She's not doing the billing. Somebody has to do the billing, but your billing doesn't even, they don't reimburse for social workers. And you cannot do incident to billing with a social worker. If you get a nurse practitioner, then it's game over. That's easy. But most of them are social workers. So it becomes a catch-22 situation. You're intentional and you're doing the right thing, but eventually the landlord wants his rent check.
They lose money every time they sell gallon milk. And that's why it's put in the very, very farthest corner in the back of the supermarket or grocery store.
Right.
So you have to walk through all these maze of things that are yelling at you to buy them that you don't need them.
We did a mental health project with one of the hospital systems, right? Where they embedded a social worker. We gave them a room. They paid us a little bit of rent, fair market value. They got 350 patients that they were rolling every couple of weeks. They would see them. They did telemedicine. They did everything, but they were very administrative and very bureaucratic. And then they killed the program. They had a grant for it. And then once the grant finished, what happened? They killed it because you know what the answer was? We couldn't support the social worker.
Right.
This is the system.
Right.
But this is different. This is a small business.
Yeah.
Maybe breaking even or losing a few dollars by providing the service. but it's a value added service.
Oh,
And
yes.
so your customer's happy,
Yeah.
and it frees the clinician, the physician, from having to sit there for 30 minutes and listen to the teenager about our anxiety.
An answer would have been
Next
for the
patient.
social worker to work with the physician, but you can't. That's
Well, but at least it's something. It's better than nothing.
Yeah. George, there's an analogy that I have in my head for running the business that kind of makes sense to me. So if I like running the business, I enjoy it. But if you think this is a good restaurant analogy, that if I were to run a restaurant, where do restaurants make their money? Dinners and drinks and stuff, but dinners of people they know, right? People walk in there, they know you, they know what to order, not giving you a hard time. If you screw up a little bit, they've known you, so it's all good. That's where you're going to make your money. Established diners coming in who know you well. Where do you lose money? People coming in for dessert and staying for 2 hours and 3 hours and chatting. You could have earned the money because it takes up your space, your time, your staff time. So my philosophy is let's give them free dessert. Someone comes in and says, we want dessert. Says, you know what? I'll give you some free dessert, but you have to take it to go. Okay, I'll take the dessert to go. But you know what? I'll free up that table because I have another family of four coming in who's going to be happy and sit there, and everyone's happy. And so I lost money giving them free dessert or broke even or whatever, but it freed up the rest of our time and staff. And even like when you're saying like bringing in all the sick visits, and that takes energy of my receptionist. She has to greet those people. I want when that phone rings, I want her to be free and available, and I want her to greet people. And so all that volume, that lower revenue that didn't need to come in, it does take away from the experience of other people. Now just give them free dessert. Make we do. George is going to get upset here, but like when they turn, when babies turn sick, how many times do you get a call in the middle of the night for the 8-month-old that has 103 fever who looks horrible and they don't have Motrin ibuprofen, which is phenomenal treating fever, and they call you, they're worried, they rush to the ER, they get the Motrin, they look better, and they go home and stuff. So starting at 6 months, we give them a bottle of children's ibuprofen. This is what you're going to use if your baby gets a fever. This is your dosage. This is your syringe. Call me if your baby looks really sick with a fever and doesn't look better within an hour or two of the ibuprofen. And it's a cost to us, but it's a really important thing to reduce those after hours calls, unnecessary visits to the ER.
So, Stephen, when you say yes to something, you're saying no to something else.
Mm-hmm.
So when you're saying yes to scheduling all these physicals in advance and making sure all the physicals are done, you're saying no to some sick appointments. How does that make the culture of the business in your own life manageable, so that you have a thriving business and you're still happy to show up every morning?
Yeah. There's always going to be trade-offs. And, so one of the things that I knew when we opened the office as a trade-off of a small business was that, being by myself and being the one responsible, I'll take call. I'm on call 24/7. The other providers do share calls sometimes. For the most part, I take the call. They call my cell phone directly. My cell phone number is actually the number on the website for after hours. And I don't get very many calls. It's not bothersome. I'm available when they need me after hours, but we don't have office hours, evenings or weekends. And because I just knew long term, if I wanted to make this work for me and my family, that I needed to work really hard during the week and go 100 miles an hour during the week. And then on the weekends, just have time off and not have to worry about being patients. And I did some nursery rounding initially. I think we all did nursery rounds, but that's moving away. Most of the suburbs have hospitals that do it. So we stopped doing hospital rounds years ago. The way it works for us is that even though we don't provide care in the evenings and weekends, we provide after hours call if they need us, but the exceptional care during the week, we don't turn away sick visits. Somebody wants a sick visit, they're coming in. We'll find what time it works for them. And this works for us because we have really good urgent care support. In our area, there's the PM Pediatrics urgent care. I think they're up and down the East Coast a bit. And their care is fantastic. I think they're an extension of us at times. I trust their care. They send us notes. We'll call the families the next morning. We always get their notes. We'll call the family and say, hey, I saw that your daughter was there for a fever last night. How's everything going? Everything okay? Do you need anything from us? But so I do think that what we don't offer, maybe that does keep some families from coming to us because they want the weekends sick visit with us. But the urgent care does a very good job. And again, if you've taught your patients that many issues when your kids are sick, you can manage at home comfortably and confidently, then they don't look for those sick visits. If you're a practice that brings in every sick visit all the time, then certainly Saturday morning hits your kid is pink eye, you're going to want to go see that doctor.
Yeah.
So it drives up the volume.
So setting limits has helped you retain staff have a healthy culture, and most importantly, you're not burning out.
About 5 years ago, we wanted to take a 2-week family vacation. That was hard, right? Because my covering doctor wasn't seeing the checkups back then. And I was like, I'm going to see all the checkups. And that was hard. So that's when I really knew it was time to finally add somebody after a dozen years or so. I enjoy the challenge. I enjoy having the other providers. So I'm still working 5 days a week, but one day I get to work from home and then do other projects and work on the practice administrative stuff. I tend to be an optimist. So I find the problems. I like solving problems. I get frustrated sometimes when I walk in the office and there's another water leak from the office upstairs.
So this is a wonderful story. So she was kind enough to say, come over to my office one evening. So I come over, and it's a beautiful office. And as we're walking by the fire truck room, there's a leak from the ceiling.
Yep.
And we had to get the step ladder and the buckets and do this before we went out to dinner. And that's when I found out she was an optimist.
Yeah.
Because this will be better in the morning. I'm like, I would have been cursing.
I wasn't cursing on the inside.
What do you do?
I usually, I'm on the computer and I have like projects that I like to do. I'm changing up some of our IT. I usually have a lot of emails or appointments or phone calls. I have the time to do that. I do a little grocery shopping. It's nice to do grocery shopping during the week and
Not working.
wife a break.
That's not work.
That?
That's not working from home. That's not even work.
Oh, no, yes. I'm not working maybe as many minutes, but it's a
I
more
know, but
relaxed
the message
pace.
you were given is I work from home one day a week. Doing administrative work at home, billing
Right,
stuff,
right.
maybe
And
some
then
telemedicine. That's working from home.
the other thing that I've done is telemedicine. So we have good space there's 3 providers here, but 6 exam rooms, which is very comfortable for 2 providers per day. We stagger the days, so there's only 2 providers. So I'm in the office on Tuesday, but Tuesday I'll only do video appointments. And so I do a lot of the older kids, the medication checks. We manage our own medications. We'll have a set video check. And so there are some Tuesdays I'll be here where I'll do telemed visits at my desk. So I'm here supporting the office, but I'm not taking up staff space.
You have any more questions, George?
No, the telemedicine is good, but you can't do checkups from home. Checkups are limited to the office.
Yeah.
We did try one time to do hybrid checkup nonsense. It's no good.
I think COVID came. There was a little bit of that for a couple months.
Yeah, it's
a little bit of.
We did it at work.
We'll
It
talk
was
at
fine,
home.
but it was not good.
No, that was barely getting by for that.
Herb, is it fun to go to work? Do you go to work for fun?
Yeah, I love Friday. I love the feeling on Friday when
Yes.
you're in the afternoon and you're ready for a weekend.
We should have a good time at work. Yes.
I
we
love the patients. Walking in that room with the toddlers is hysterical. You never know what they're going to say. They're admiring their sparkle shoes and just talking about random stuff. And I learn from them. I talk to the teenagers and they're telling me they're into something. I'll look it up on the internet and start asking them questions about it. I think it's, if you enjoy people, getting to know people, I think it's
the pediatrician, you are the most popular physician of all physicians.
Yeah.
Everybody loves their pediatrician.
Yeah.
They're like rock
Right.
stars sometimes.
I just think there's a difference between having fun and enjoying what you're doing.
Uh-huh.
So it is work. And when you have a leak in an exam room, there's nothing fun about that.
Right.
And if your expectation is that somebody's going to serve you a cocktail, mimosa when you walk in and give you a back rub, and then at lunch, they're going to cater your food in. And no, not even the top much richest CEOs of the world get that kind of treatment. It's work. And there's going to be aggravation and challenges every day.
Yeah.
But it shouldn't be that you dread pulling into the parking lot.
Well, no, I
So there's a middle ground.
Certainly anybody who's in that situation should be able to talk to somebody or now just figure out what is it that they're dreading and what can they do to change it. Unless it was a temporary situation, that people need to think about what they can change.
Yeah.
Have the ability to change. The nice thing about being a physician is that I don't think you're ever going to be unemployed. There's always places where you can go from most parts of the country to work while you get your bearings and figure out what's meaningful to you.
Yeah. But if your expectation is you're going to have fun and you're going to see 3 patients a day,
that's boring, right? You see these concierge practices, they see 10 patients a day or 5 patients. I'm like,
I
was like
what
that
do you
is
do the rest of the
boring.
day?
I was like,
What do you
I
do?
need to be in and out.
Could you imagine talking in a concierge practice to Herb for an hour?
No.
I wanna
I
do
remember
that.
when I was doing my that's why I knew I for a brief moment I was like, well, I don't want to be a pediatric specialist and stuff, but I would be in those appointments in my residency. I'm like, just in that room for 30 minutes talking about the same topic over and over. And we have a lot of repetition, general pediatric, mind you, a lot of repetition, but the breadth of what we talk is so much more. And I just couldn't focus on one thing all day, all the time. Yeah.
Now, Stephen, what have I not asked you that you think is important to talk about?
Yeah, great question. So I do think that practices are very different and diverse. I can't say the experience here is similar to any other experience in the country because different populations, different insurances, different everything. But I do think though there are practices that for whatever reasons have a culture that works for them and it's positive and enjoyable and they're relatively more successful. And I think practices that are independent who don't feel like they have that same enjoyment to look to see what it is that they can be doing differently. And I think Chip Hart's a fabulous resource. He can probably look at your practice and figure out what are the couple things that maybe you could tweak a little bit. And if you want to be intentional about the changes, I think those are important. And to that extent too, I do wish, yes, as far as like training and mentoring, we used to have medical students in here. I had medical students from Georgetown and GW or Children's, and they would come every month and I'd alternate them. And I had a resident here for a couple of years, but we got busy. So I stopped that, put that on hold, probably pick it up sometime in the future. But I really wish the residencies would send people interested in primary care into offices that are feeling good, just to give them the impression, or not impression, just give them the view of what can be done. Because I think sometimes it's doom or gloom. You have doctors that are practicing for many decades, more decades than me, and they always talk about the way it used to be. It's no good. You can't do it. And you need to join this and that. And it really puts a negative light. But if you can come and see a practice that's different, oh, you know what? I can go into private practice. I think there's a way to do it. I had the benefit of when I was in residency, I was able to work for 1 day a week for 2 years in a community practice. And it was in Atlanta. And it was the oldest pediatric practice in Atlanta. And it was pretty well run. And I saw that. I'm like, oh, this is a better one. Right. I get it. Okay. So we don't have to do things the same way as everyone else. Anyway, so I just encourage practices just to think outside the box and think about if they can change their
advice,
their culture.
I do think that the pain point there is that pediatrics pays so little that it really is hard to make the argument for a young person. And we just had this discussion the other day. A young medical student, she likes pediatrics, but she's looking at psychiatry because the starting salary is $300,000, and she can do it from home. I'll be home 6 hours a day, $300,000, or I can show up to George's practice, work every other weekend, run like crazy, because that's what pediatrics is. You got to go from one room to another and get the call from the daycare that the kid's got a sniffle and be torn like, do I go? Do I stay? What do I do? And I get paid half this much to start. And how do you just go, as long as you can take it, listening to people about their mental illness all day, because that gets old. You can't manage it. If you love it and you can take it, sure, but you're not going to get the enjoyment of seeing a kid smile.
I can't speak to financially how you might compare to other practices, but I do think practices that are fairly robust, successful, I think financially they'll do better. You're overpaying for services, so you're decreasing the income and the revenue. Adding the Bright Futures guidelines, those are paid pretty well. If you can add those to all of your checkups, we do every Bright Future screening, all the mental health screening, and we paid for a lot of those. So it makes those checkups more revenue generating. So it works out better. But I think, if the goal is to make more money, then yes, maybe you'll do something else, or I'd probably be an investment banker or something.
Absolutely.
But
would you be happy?
There's always someone with more money than you. There's always something else better than you. But no, I think the goal is to just be content, to just find your arm, be content. But I do think, though, from just going back to what we're talking about the financial benchmark, like you can get your practice to a better place, in a place that you're feeling more comfortable and you're not always to feel like you're chasing things.
I will push a little bit back on that. I think all of you said is right. We need payment to be addressed, because it's just the nature of life. Nobody beats the clock. We all get old.
Yeah.
And we need some happy, engaged workforce that's coming behind us to take demand. Payment to them is important because they have huge financial burden from student loans. Will the grandchildren of our patients have a pediatrician if we don't address payment?
No,
or is it really inefficiency?
It's payment, George.
I think there are some payment issues, but there's a heck of a lot of inefficiencies, especially in a pediatric practice.
But George, you're supposed to do these mental health screenings, and sometimes Medicaid in New York pays you SIPO.
Most of them pay.
And Medicaid in New York, if you're not a patient-centered medical home, will pay $45 for a visit. Oh, it's no way you can make money at $45.
No, you cannot.
And then in Virginia, A 99213 on Medicaid is $60. Really tough to make money with that. And in Virginia, Medicaid doesn't pay for the G2211, Zippo. Care coordination, Zippo. So you're trying to do the right thing, but you don't get paid for it. So you can't do the right thing. You got to find another runny nose to get the $60. You can squeeze 5 visits in an hour if you have a lot of Medicaid patients.
Yeah.
And that doesn't work.
Yeah.
And they need the care too.
Yeah, I know, but in
So
defense of Medicaid, they're not $45 visits anymore. You know that.
no, that they are, because I've seen the numbers and they are, and you've seen the numbers and they are.
Not in New York.
Yes, sir, in New York.
Yeah. I'll never argue against better payment for anything. So
No,
I'm
you
more
should
than
get
happy
better
to
payment without question.
down.
There should be parity with Medicare.
Yes, I think
Parity with Medicare.
if there was Medicare parity, that would be there is that on occasion. I think some of the states will do it temporarily.
There is. If there was parity in the Medicare, would it be good?
No, not good enough.
See, I knew that. So that's where Medicare parity, in my opinion, is for Medicaid line of business is perfect.
No, it's not good.
Fix the efficiency.
They're not half a kid. A kid is not half a person.
But what is good enough? What is good enough?
At least 150% of Medicare, because our adult colleagues tell us that they have to limit the number of Medicare patients they see because they lose money. I think taking care of a child is just as important as taking care of an adult. So if it's a 99213, I deserve the same money as the internist. If it's a 99214, I deserve the same money as the internist.
Absolutely.
If it's a 99215, I deserve the same money as the internist because the child's not worth half an adult. I deserve to get paid the same as my other physician colleagues in other specialties.
Correct.
Why should I get paid $180,000, say $160,000 to start, while the radiologist gets paid $400,000 to start and only works 40 weeks a year? That's just not fair.
You're correct on that. I'll give you that.
That is not fair.
But we can.
So what are you telling me? The children don't matter?
No, children matter. Remember.
So let's ask for enough payment so we can do the work we want to do it right and give access to everybody.
Okay. No, I agree with you with that 100%. But you can control today efficiency in your office.
We've taken enough time, Steven. Thank you so much.
Well, thank you so much.
It's always a joy to see you. But
thank you.
I love listening to your podcast and hearing about all the different pediatricians and pediatric related people around the country giving their stories. So thank you for doing that.
And when you start with PCC, you get more than an EHR. As an active participant in the pediatric community, we're proud to offer a lively peer community of PCC EHR users, a free annual users conference, and new resources that empower you to prioritize your patients. Learn more at pcc.com. Again, pcc.com.